I'm Dr. Ronald Berkman. Today we'll be talking about contraceptive use in the United States and the evaluation of efficacy, particularly as it relates to Food and Drug Administration approval for a new contraceptive. Certainly contraceptive use in the United States is important that we understand some of the demographics, particularly as it relates to individuals who may be at risk for unintended pregnancy. This is part of a grouping of videos, assigned reading, and a case discussion session which will be coming up, which after participation, participants should be able to describe the need for contraceptives in the United States, the population using contraception, the method used, and the methods used to determine efficacy. And that's the purpose of this particular video. In an additional video, as well as during the discussion session, we will be covering structural features of contraceptive hormones, the mechanisms of action of those hormones, challenge in formulating contraceptive hormones, and approaches to managing certain contraceptive problems. So let's look at the need for contraception in the United States. And this is data based in 2014, which is the latest time period in terms of large contraceptive studies looking at demography and other issues. So in 2014, there were about 61 million U.S. women of reproductive age. And about 43 million of these women, or 70%, were at risk of unintended pregnancy. Keep in mind that couples not using any method have approximately an 85% chance of pregnancy within 1 year's period of time. So again, risk of unintended pregnancy is high among individuals who don't use birth control. In the United States, the average desired family size continues to be about 2 children. So in order to achieve this, couples must use some type of contraceptive method for about 3 decades. If we examine the unintended pregnancy rate in the United States, you can see that there has been modest improvement over the years. Over roughly, 35 years ago in 1987, the rate was about 55 to 56%. By 1994, it had dropped to about 50%, where it sort of fluctuated over the next number of years, such that the most recent data would suggest that the unintended pregnancy rate in the United States is about 45%, a very modest improvement, and certainly one would hope that one can further reduce the unintended pregnancy rate from its current level of 45%. So let's examine some of the characteristics of women who are of contraceptive age relative to their actual use of contraception. So if we look at age and how this relates to it, about 99% of women aged 15 to 44 who have ever been sexually active have used contraception. So awareness of contraception is certainly there among reproductive age women. About 60% of women in the age group currently are using contraception. Overall, however, 10% of women aged 15 to 44 who are at risk of unintended pregnancy are not using contraception. If we look at the breakdown by young and older women, women aged 15 to 19 have a rate of about 18% of not using contraception. And even women aged 40 to 44 have a rate of 9%, and these are women who probably feel they're beyond the age when they can get pregnant, and unfortunately, this may not be the case for some of them. If we look at race and income level, you can see there's not huge differences, with the exception of women of black race seem to have a lower contraceptive use rate when they're at risk of unintended pregnancy compared to Hispanics, whites, and Asians. If we look at income level and being above, say, 300% of the federal poverty level or well below it, there's really not much difference in terms of contraceptive use by income level in the United States. If we look at marital status and religion, the use of contraception by marital status, certainly currently married, about 77% of women overall use contraception, but over 90% use contraception if they're at risk of unintended pregnancy. You see in the never married group, the overall use is about 42%, but you need to keep in mind there's a substantial proportion of women in this particular age group who are not in a relationship where sexual intercourse is an issue. But if they're never married and at risk of unintended pregnancy, the overall rate is about 83% of use. If they're unmarried, cohabiting, however, at risk of unintended pregnancy, this rate of contraceptive use goes up to about 90%. Among women who are Christians, apparently the only religious group studied in this big survey, Catholics have a risk of unintended pregnancy rate roughly the same as Protestants, roughly in the neighborhood of 90%. So what are the methods that are used as an overview? About 72% of women practicing contraception currently use a non-permanent method, whereas another 22% roughly rely on female sterilization and another 7% roughly rely on male sterilization. Oral contraceptives and sterilization are the two most commonly used methods since 1986. And when you look at the use of sterilization, hormonal methods, and the IUD, again, methods which theoretically have the lowest failure rates, and you look particularly among practicing Christians, you don't see huge differences. Again, Catholics at 68%, mainline Protestants at 73%, evangelicals at 74%. Of interest, Catholics who use natural family planning really comprise only 2% of those at risk. So natural family planning, despite religious objections, shall we say, to the use of the usual methods of contraception within their religion, only a small percentage rely on natural family planning. If we look at users of hormonal methods, about 80% of sexually experienced women have used oral contraceptives, and the pill is most widely used by women who are white, younger age group, 14 to 29, never married but cohabiting, as well as college graduates. The proportion of contraceptive women who have ever used the other hormonal methods has increased over the years. If we look at Depo-Provera, about 5% of contraceptive women used it in 1995. This has risen to 23% in the age or the year range of 2006 to 2010. The contraceptive patch was used by less than 1% of women in 2002 and has risen to about 10% of women by 2006 to 2010. And the vaginal ring, and we only have the later data, is used about 6% of women in the range of 2006 to 2010. What about the use of LARC methods, that is the long-acting reversible contraception? Use of these methods has steadily increased among contraceptive women, and this particularly as it relates, I think, to the IUD, where people finally realize that these are safe, and all the issues that have related to the Dalkon and Shield has sort of been pushed aside. So in 2002, the rate was still low at 2%. It had risen to about 7% by 2007, 9% by 2009. And in 2014, about 14% of women use LARC methods, about 12% the IUD, and another 2 to 3% the implant. The groups of contraceptive women who most often use either the IUD or implant are as follows. They are in sort of the mid-range of reproductive age, 25 to 34. Of interest, a higher proportion have been born outside the United States. More live in a Western state. Most report the religious affiliation as other. And many have stopped using a non-LARC method before they went on to a LARC method. Again, what this means from the standpoint of the population and why this particular population are more used to or willing to use LARC methods is unclear. When you look at sterilization, about 7% of men aged 15 to 44 have had a vasectomy. However, this proportion increases with age, in that 16% of men aged 36 to 45 have had a vasectomy. The reliance on sterilization, that includes tubal ligation or salpingectomy, as well as vasectomy among subgroups of women, are women who are of black or Hispanic race, age more than 35, having 2 or more children, living again below 150% of the federal poverty level, having less than a college level of education, living outside a metropolitan area, and with public or no health insurance. So that one would assume that this then suggests that poor individuals who are older, who have completed their families, who live, I guess, in rural areas, are more likely to rely on sterilization than other women. What about condom and withdrawal? In 2014, about 5.5 million women relied on male condoms, so it was not a minor number of women that relied on condoms for contraception. Every use of male condom increased from 52% in 1982 to 93% by 2006 and 2010. Some of this may relate to dual use in terms of trying to reduce the risk of sexually transmitted diseases. And certainly the dual use with another method occurs in about 85% of sexually active women. Women who rely most commonly on condom use are young women, teenagers in particular, also born outside the U.S., reporting their religious affiliation as other, having never been pregnant or desiring at least one child or more, being a college graduate, and uninsured. So a lot of this may have something to do with the cost of contraception, in that condom being less expensive, particularly in the group that's young in particular. The proportion of sexually experienced women who have ever used withdrawal increased from about 25% in 1982 to 60% in the range of 2005 to 2010. Why this has occurred is unclear. So with that background, let's look at efficacy in contraception. Certainly a big decision point is how useful is my method of contraception in terms of preventing pregnancy. And there's 2 methods that are utilized for estimating contraceptive efficacy, which we'll go through. Both types have their pros and cons, and it's important to recognize the Food and Drug Administration mandates certain types of studies and analysis in order for a drug to gain approval. The rate that is most commonly used is the so-called Pearl Index, which is the number of pregnancies multiplied by 12 divided by the number of women and the total months of use by those women times 100. Or you can use times 13 times cycles when in fact you're looking at 28-day cycles. So one of the issues with the Pearl Index is that, again, depending on the distribution of the pregnancy, you can get rates when in fact that vary when in fact there's not much difference. For example, here is a example of 100 women in a study. 10 pregnancies occurred in the first month only. Group A were followed only for 6 months. Group B were followed for 12 months. And you can see when you calculate the Pearl Index, the group that was followed for a shorter period of time ended up with a pregnancy rate substantially higher than the group that was followed for 12 months, yet the total number of pregnancies experienced were not different. So the positive side of the Pearl Index is very simple to do. It's good for short duration studies with very few dropouts, but clearly is better if the pregnancies are distributed evenly over time. But it's a crude rate. It's poor if the failures occur early in the exposure, for the example I just gave you. And in contraceptives, it tends to favor less fertile couples and better users of birth control. The life table analysis is a complicated way of doing this, but it calculates failure rates for each month of exposure and probably gives a more accurate picture, but it's very difficult to do. However, women leaving this study for any reason other than pregnancy are removed for further analysis, though their length of exposure onto exit is counted in the analysis. The positive thing about a life table analysis, it's good for pregnancies which are not evenly distributed over time. It can compare studies with different rates of exposure. However, it is much more difficult to do and doesn't solve the problem of dropouts who don't communicate the reason for leaving the study, i.e. were they pregnant or was there some other reason. Now, what about getting Food and Drug Administration approval for a new drug, including contraception? It's important that I think people at least recognize there are sort of 4 phases of studies when a new drug or a device is coming to market. Phase 1 is basically, is the drug safe? And the company uses varying doses in a very small number of subjects to determine if there's serious side effects and to have some determination, does the drug appear to be overall safe, particularly in a dose that is likely to be effective based on earlier animal studies or other types of study. Phase 2 is basically trying to determine, does the drug work? Here again, relatively small numbers of subjects, a few dozen at most, to determine what dose or doses provide the desired effect and an acceptable side effect profile. Phase 3 is really where the larger studies are done, and it's really to determine, is the drug as good or better than drugs used for the same reason? And so you need larger studies to have a statistically significant estimate of efficacy, and also to better define side effects and possible serious sequelae with its drug use. Ideally, one would like to use a randomized clinical trial design to compare, let's say, an OC versus another OC. As we have learned over the years, this is rarely done. Finally, phase 4 studies is there a risk of serious sequelae, and is that risk reasonable? And this is done post-marketing when the drug has already been distributed and when large numbers of patients have been using the drug, and one wants to get a better estimate, for example, with the birth control pill, of how frequent does, say, venous thromboembolism occur according to different doses or formulations. So, for approval of a new contraceptive, the Food and Drug Administration guidance is as follows. One does obviously the first 2 phases, but the phase 3 arm, the one that really is looking at efficacy as well as the rates of side effects, needs to be a phase 3 single arm, meaning it doesn't have to be a randomized trial, open label, which means obviously people know what's being used, and it has to be of at least 1 year's duration or covering the maximum duration of use in the label. For example, with the IUD, this could be 3 or 5 years. It would be the duration in order to get a label that says it's efficacious for that period of time. At times, the Food and Drug Administration may require 2 trials. If it's a totally new drug or device, which they call a new molecular entity, one needs 20,000 evaluable menstrual cycles with at least 400 subjects. If it's a non-NME study, that is, let's say a slightly different version of a pill with the same components and basically the same delivery system, one needs only about 10,000 evaluable cycles with at least 200 subjects. The means of evaluating efficacy is the Pearl Index. And the Pearl Index is performed on subjects who continue to be sexually active but who are not using backup contraception. Life table analysis is only used to provide supportive information. So here is data actually from a new contraceptive patch called Twerla, which was just approved in the last few months by the Food and Drug Administration. And it's like the other patch. It's changed weekly, used for 3 weeks out of 4. But different than the other patch, it contains ethinyl estradiol and a different progestin, levonorgestrel. So the efficacy study, which led to Food and Drug Administration approval, was a single-arm, open-label trial of 1,735 subjects, which involved basically 15,165 cycles, so very close to the new NME type of study. But it's certainly a wide range of number of subjects were in this. And when they calculated the Pearl Index, as shown here, you can see there were changes by a patient weight. in that patients who are, or subjects rather, who are between less than 25 BMI to as high as 30 had rates that were below 6 failures per 100 women years. But once you got to women who are above 30 in terms of their BMI, the Pearl Index increased substantially. And when they plotted this out as shown here, you can see that it was sort of a steady increase based on the population studied. But they made the decision, along with the Food and Drug Administration, to essentially indicate in the product labeling that women with a BMI over 30 should not use this contraceptive. And this is probably based on the failure rate at this point becoming in the high range of failure rates of women using the hormonal contraception. And as is shown here, you can see that the typical use with a pill is about 9%, and certainly with a patch also is roughly 9%. And so this was creeping up in that level, and that led to the labeling of this new patch, Twerla, to not use it in a woman who is 30, a BMI of 30 or higher. So with all of this, and again with some understanding of how efficacy and who uses the drugs and so forth, why is there a continuing high rate of unintended pregnancy? As we've already shown you, teenagers and women in their 40s are more likely to experience an unintended pregnancy and undergo an abortion. And can we reduce that further? Further, about 10% of women in the United States are at risk of unintended pregnancy, but not using contraception. However, when you look at the United Kingdom and France, the rate who are not using contraception yet at risk is only 3%. So how do we address that? How do we achieve this type of rate that other countries do? LARC methods, since there's no regular activity such as remembering to take a pill every day or change a patch every week, certainly have low typical use or theoretical use failure rates. However, among women at risk for unintended pregnancy, only about 10% use an IUD, whereas you look at, again, France, 20% of at-risk women use IUDs. So how do we encourage individuals to use the so-called LARC methods where there's no need for a regular activity to use it appropriately? So what sort of strategies? Well, one of the areas that probably should be addressed is access and cost. If we recall from one of those slides, you had college graduate women who were cohabiting, who were using certainly other methods other than hormonal contraception and LARC methods. And this probably had a lot to do because of cost. And this could include even those who were insured, in that copays can still be a major barrier. When health systems such as Kaiser reduce or eliminate copays, one sees increased utilization. Keep in mind that if the Affordable Care Act is eliminated, which is the desire of certain groups within Congress, it is likely to exacerbate the barriers of access and cost. Certainly reducing side effects and having better counseling is important in reducing unintended pregnancy. But it's also important that if you have an individual who won't use what you think is the most appropriate method for them and wants to use another, you need to support her decision to use her method chosen and help her use that method to the best of her ability. Certainly, we would like to overcome resistance to LARC methods, but again, that takes a lot of patient education. And also improving availability of emergency contraception. And a lot of this relates to cost and relates to having uniform provision of emergency contraception without prescription across the country. One other thing that briefly should be addressed is many women have the fear that using particularly hormonal contraception puts them at substantial risk. And this is a chart that looks at some of the activities that we deal with every day, such as riding a car, possibly worried about fire, riding a bicycle, and riding in airplanes. And we contrast this with pregnancy as well as pregnancy prevention. And you can see that use of the pill in non-smokers, even smokers, again, have rates that are substantially lower than most of the activities we embark in on a daily basis. However, it's important to note under pregnancy that the rate or risk of death since 2006 through 2019 has in fact increased. And certainly this is an area that we in obstetrics have to address through better care, particularly in the areas of recognizing the treatment appropriately of particularly postpartum hemorrhage and hypertension in pregnancy. So this completes this particular video presentation dealing with some of the demographic characteristics of women using contraception, as well as a brief review of how efficacy is determined in contraception and how to hopefully overcome the barriers that would lead to a reduction in the unintended pregnancy rate.